Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello and welcome to another episode of the INS Infusion Room. Today we have very special guest, Chris Cavanaugh in the house. Welcome, Chris.
Thanks, Derek. How are you today?
I'm doing great. I'm so happy that we could finally connect and have this really impactful discussion. So for you listeners or viewers, depending on how you're tuning into the podcast, we're going to be discussing breaking bias at the bedside, substance abuse, and equitable care. A very important discussion to have. So if you don't know Chris, I'm going to give her a moment to introduce herself and talk why this discussion is very near and dear to her heart.
Thanks, Derek, and thanks to the INS for having me on this. I really appreciate the opportunity. I have been in industry as a clinical specialist now for almost 20 years. And prior to that, I've worked in pretty much every type of healthcare environment, acute care in the ICU and on a PIC team. I've done home infusion. I've worked as a legal nurse consultant. I've done education and training. I've also worked in long-term care as a liaison to the pharmacy. I ended up in this world to start with because I decided to go back to school and get my master's degree when COVID hit. And in my process of getting my master's degree and going back to school, my mentor challenged me. I was going to do my capstone project on something related to vascular access, something that, I've worked with before. And she said, think about trying something that makes you uncomfortable. Well, that was easy. The first thing that came to mind, the first thing that makes me uncomfortable was the patients that we struggle with every day because they have some type of history with substance use. The age-old question of, do you put an IV in them? Do you not put an IV in them? What is the right thing to do? What is the best thing to do? And I said, that bothers me. That ate away at me. And it's also a personal issue for me as well because of a family member. So I said, let's look at that. And I'm glad that she challenged me because she really changed my own personal biases toward the population and really opened my eyes to what equitable care and harm reduction can look like and how it can be safely done and how we can care for these patients with dignity, which I think is a lot of what we struggle with every day.
Agreed. That's a beautiful story. And you mentioned equitable care. What is equitable care to you?
That's a really good question. Think that when we're talking about this population in particular, we come to the bedside with biases. I think it's inherent in us being human, right? We certainly all want to do the best we can for our patients, but we anticipate or maybe even expect sometimes that the patients will have the same buy-in. They'll have the same skin in the game, so to speak, and want the best pathway to get healthy. Not all of our patients are willing to do that. And we have to take that a step further and say, despite your health history, despite your socioeconomic history, despite your willingness or unwillingness to work with us, we need to treat you as best we can with the tools that we have. And I think sometimes we fall short in that.
I think sometimes we look at planning as black and white within nursing, and it's not.
right? We're always meeting the patient to where they are. So, I would agree with you 100% on what you just said about equitable care. So, how does equitable care apply to across the full spectrum of infusion therapy settings? So, we have outpatient, we have inpatient, home infusions. So, how does equitable care apply to all those settings?
Yeah, that's a really good question, and probably the biggest challenge that we have, because especially with this population, these patients typically don't need care for a couple of hours or a couple of days. They need treatment for days to weeks to months. Quite often, when they hit our ERs, they're in really bad shape. They're septic, they have osteomyelitis. We see a lot of septic abscess, spinal abscesses, things of that nature, things that need 4 weeks of antibiotic therapy, 6 weeks of antibiotic therapy, which means for most patients that come in with osteomyelitis, the typical treatment would be get them stabilized, get them on, give them a PICC line, get them on a treatment regimen, and then send them home with home care, and they can continue their treatment at home. With this population, we look at them very differently, and that's where the challenge comes in. We don't trust that they're going to use the PICC line that we give them in the proper way and only for prescribed medications. We are concerned about potential liability as a clinician, as a provider. We see this not just with the nursing staff, but with the physicians as well, and all the mid-levels. They all have this what happens if concern. And sometimes I think we apply it too vigorously
Hmm.
to this population, where we don't necessarily apply it to other populations. And quite honestly, this population can be cared for outside of the hospital with the right support, but they often need more support than our non-substance using patient population.
Yeah, I would agree 100%. And I think a lot of the question comes from what I've heard in practice is what is a liability? Vascular access nurses, it's ingrained that we have to evaluate the resources available to care for the device in which we're placing within the patient. And I think a lot of vascular access clinicians feel as though that maybe with this large risk that they're evaluating and seeing is that they fall short on that. So, when we're looking at a patient coming, like you mentioned, coming in through the ED, they transition into inpatient. Maybe they're on a med-surg unit, starting the initial rounds, stabilizing, and then they transition home. And that's where the true issue is, right? And that's where the concern is for liability and feeling as though that it's going to be tampered with. So how can infusion nurses balance safety with avoiding assumptions about misuse and tampering?
I think we have to have very honest conversations with our patients, just as we do with a patient that has a history of cancer or a patient that has a history of diabetes or COPD. Our patients with COPD, for example, we don't require them to stop smoking before we treat them. Our diabetic patients, we don't require them to stop, eating carbohydrates before we treat them. I think we have to understand that if we have a patient with a history of substance use, that substance use may continue, but it can continue without it necessarily impacting the care that we're giving them for their infection, whether that be IV antibiotics or whatever else. We also, I think, need to keep in mind that there are ways to treat addiction now that we never had before. Sometimes, not sometimes, I would say it's part of the requirement to be successful. You need to treat the addiction as well as, just like you would treat the cancer and the you don't stop treating cancer because you're treating an infection, right?
It's not on a separate plan of care. It's actually integrated
Correct.
into the patient's plan of care, right?
Exactly. Exactly. And I think we have to have that conversation with the patient. We are going to put this catheter in, this PICC line. It goes from your arm to the big vein right above your heart. And if you mess with it, it can kill you. We have to be very upfront and honest with them. This is not for you to use. This is for us to use to give you your antibiotics to treat your endocarditis or your osteomyelitis.
And I know that we're talking about IV substance abuse, but are they the only patients that could or would tamper with the device? No, right?
No.
So this
No,
conversation could be had across the entire spectrum of all patient types because let's face it, there are other risks associated with tampering. For instance, infections, right? If we have someone that's taking the needleless connector or end cap and taking it off, putting it on, leaving it open, there's lots of different varieties of how an individual could tamper with the device. That puts them at a higher risk. So this is not the only patient population that we should be considering or ranking a little higher in my eyes.
absolutely. I think we need to look at it like a safety precaution, right? We have fall precautions for people who are unsteady on their feet or taking pain medication. We have seizure precautions for our epileptic patients. I think there is a category of patients that need PIC precautions or vascular access device precautions, tamper evident technology, behavioral contracts, things of that nature that need extra monitoring, extra education. And I think it really needs to be looked at from a patient safety perspective. Because you're absolutely right. We could be talking about psychiatric patients who may want to mess with their catheter to get more days in the hospital. Incarcerated patients like to create more problems so that they get different, people who are attention seeking. Then we're looking also at patients who are that are cognitively impaired, right? They're not necessarily aware or capable of being careful with their catheter. So there's those risks as well. And the pediatric population too, that we just maybe can't really explain what's going on and why they shouldn't touch, right? So we have that issue as well. So all of those patients really kind of fall into this category of needing some additional coaching and support with their IV catheter.
Yeah. And I think the solution has been for years, well, from the organizations that I was associated with, it was if a patient presents with this risk, then they must go to rehab or long-term care for short time to receive these infusions. But let's face it, they deserve the equitable treatment and same access to these antibiotics or infusions within a reasonable setting. So if the home setting is a best fit for their plan of care, then we need to look at adaptations to that plan of care to make sure that we're meeting them to where they are.
Absolutely. Absolutely. A lot of facilities, unfortunately, feel that they are stuck in keeping these patients in-house, inpatient for the length of their treatment, which could be 5 to 6 weeks. Alternatively, there are some rehab facilities, skilled nursing facilities that will take these patients. But then you're often sending someone inappropriately into a setting that is not really designed to care for them, not really designed for a younger patient, not an elderly patient, right? Where they're not necessarily getting their other needs met, whether that be cognitive or behavioral or other. So I think there's a lot of challenges there, and these patients will feel trapped, which will honestly work as a boomerang effect and force them to leave AMA often because they feel stuck or
Yeah.
imprisoned, and it's
Yeah.
sometimes not necessary.
They're in the wrong
It's
setting. We're
exactly.
placing them in the wrong setting.
Exactly. I think we can do a fair assessment of their home life to find out what their support system is. And you'll find that a lot of these patients may have a great support system at home that you can engage and that are willing to participate in helping to care for this patient. And I think a lot of times we automatically rule that out, and we shouldn't. We need to explore that as well.
So there's stigma. How do we get rid of the stigma?
Yeah, that's probably, the biggest challenge, right? And I have to say, I was probably right up there in believing that a lot of this had to do with choice.
What was your
That
turning moment?
It was when I was interviewing some of these patients for my master's degree, capstone project. And as I was interviewing them, I was also doing some research about addiction in general because I needed to understand it better. And what I learned was that these patients' brains are wired differently than a non-addicted patient's brain, which was surprising to me. So they really don't have much of a choice. Or if they do, I don't want to say if they have a choice, they do have a choice, but they're predestined to go down this road. Their brain is wired differently than mine, than people who are not addicted. And you start using different substances, it continues to remodel the neurons and the thinking pathways in your brain to drive the addiction and drive the abuse beyond what you can control a lot of times. And I really didn't understand that. I was always a believer of, if you want to get help, there's help out there, you can get it and we can fix this, right? And what I found was it could be predestined to get cancer and we can treat it as long as we're willing to go through that process, right? And addiction is kind of the same way in some of these people. And so that really opened my eyes.
Yeah.
That it's not a choice necessarily, and it's awfully hard work.
Yeah.
Once you start down that road, because the substances that you choose to use are working against you and encouraging
Yeah.
the addiction.
And that is a challenge, and it's a full specialty, right? So we have specialists that we can incorporate into the plan of care. So if
Right.
we were to work with discharge planners, case managers, or addiction specialists, how can we incorporate them better into that transition?
Absolutely necessary. And I think that care needs to start from admission because these patients have a psychiatric diagnosis. They need to have some type of behavioral health consult caring involved in their care while they're inpatient because the risk is not just for them to use when they're outpatient. There's also a risk while they're inpatient as well. They can get pretty creative, as a matter of fact, as I'm sure some people have experienced. But I think if we can get behavioral health involved from the beginning, get them on some type of treatment for, there is medical assisted treatment that we can provide for them while they're inpatient and set them up with outpatient that can help with the cravings and the addiction. We can help them with counseling from the beginning. When they first get to the hospital, they're really sick. They're not going to have cravings to use. It's not going to be an issue for the first day or two until they start to feel better. And then we have to address that issue, and it has to be on the front side. Discharge planners can do a great job at assessing the home situation and finding out if this patient has a support system and how involved that support system is
Yep.
willing to be. And looking at that as a first option versus a last option.
Yeah. No, I think you're right. And, just to kind of reiterate, we're not telling clinicians just to open the gates and place every line without consideration. We
Absolutely.
definitely want to bring light to this topic, take out stigma, and make better decisions for our patients. Explore new treatment routes, explore new options to incorporate into our plans of care. But ultimately, we do want to practice safe care. And at the end of the day, we want to focus on the best outcomes possible. But, it is risk versus benefit. And we apply that in the plans of care every single day of our patients. And, that holds true to this topic just as much as any other.
Absolutely. Absolutely.
So, what policy level barriers are you seeing that may prevent unintentional limit and equitable care?
Yeah, a lot. Well, part of my research for my master's degree was I surveyed 100 hospitals across the United States 50 were above 500 beds and 50 were below 500 beds. So I got what I felt was a good cross section of the smaller hospitals, the bigger hospitals, cities, small towns, and university hospitals to community hospitals. And I had a set list of questions to try to understand what their policy was for treating these patients. What's your policy? What do you typically do? Unit do these patients land on? And what I found, shockingly, was that it was a rare hospital that actually had a policy that addressed patients with a substance use history. Most of the time, the planning for these patients was completely individualized and fell back on the nurse manager of the unit that they happened to land on. So if it was a patient that had endocarditis, for example, and needed to have valve surgery, they would bring them in, get them stabilized in the ICU, take them to surgery, and they would land on the cardiac surgical floor, and that nurse manager would then have to kind of guide the care, and there were not a lot of rules to follow. There were facilities that have security sweep their room, do limitations on visitors, maybe no visitors at all. There are facilities that confine patients to their rooms, facilities that employ sitters, live or telehealth sitters. There were facilities that were not allowing PICCs or midlines to be placed, and they would be actually giving these antibiotics IM only, or placing an IV for one dose, removing the IV and placing an IV for the next dose.
Yeah.
It was just all over the board. There was and multiple treatment plans for multiple patients within the same hospital. I would get feedback, well, some of these patients land on this unit, some land on that unit, so we don't have any consistent protocols or policies to follow. And I think that's really where we fall down as a healthcare system. This is a classification of patients that I think we need to plan for and create policies to and to provide equitable care and equitable treatment for them.
Agreed. I couldn't agree more. So I would like to do a bit of an example. So can you provide us a patient scenario in which they transition through their healthcare system and receive equitable care? So a patient within the population that we're discussing, they received what does it look like for them to receive equitable care? Do you have a specific example or something that you can talk through that gives a better insight as to what we're recommending?
Absolutely. Thanks for asking. I've got a great example of what I call a success story. So this gentleman was a 43-year-old opioid addicted veteran, presented at the VA ER in septic shock. He had endocarditis, and he had been treated for endocarditis on and off for the last year, but never was able to complete a full 6 to 8 weeks of antibiotic therapy. At this point, once he was brought in the ER, he was stabilized and placed in the ICU, started on broad spectrum antibiotics. He was on pressors. Once he was stabilized, they decided they needed to take him to surgery. He had mitral valve replacement surgery, and then they put him on a cardiac step-down unit. At that point, they decided to remove the central line that was in his neck and give him a PICC. This facility had a great history of treating patients with substance use issues, and they had tamper-evident technology as part of their treatment protocol that they used on all of their vascular access devices. They also had a behavioral health contract in place. So before they placed the PICC, they covered this contract with this patient. He understood the risks. He accepted the risks, accepted the consequences. If he decided to use the PICC, he was reassuring them that he wouldn't, and swear to up and down that he hadn't used in months, and was, a very typical convincing patient who seemed very willing to participate in his care. He was also very lucky that he had a great support system. Still married, and he had teenage children at home that were able to support him in his care. So they placed the PICC He was discharged from the hospital to home with a tamper-evident device in place and home care to support. And his wife had agreed to assist in the monitoring of the treatment. He was able to complete 7 weeks of antibiotic therapy and recovery from his open heart surgery. And to my knowledge, and I haven't, of course, I've lost touch with him, but he was sober the entire time while he was being treated. And I hope my wish for him is that he has remained sober and kind of got a new lease on life. That's certainly an ideal situation, but
Yeah.
he was able to remain sober for the 6 weeks. He was also treated in hospital with medical assisted treatment for his substance use, which helped him in that from the withdrawal symptoms. I think that's one of the biggest challenges we have is that these patients go through terrible withdrawal symptoms and just being in the hospital is a trigger to use. And so we
Mhm.
need to address that. I think
Mhm.
if we're able to, it opens up another window for them.
Yeah. Lots of barriers from many different angles, lots of stigmas as they navigate those waters of sobriety and trying to live the healthier lifestyle that we're educating to, but not necessarily always giving them the tools they need to be successful. Unfortunately, that's kind of where we are. Hate to be the bearer of that news, but we're not doing that
Absolutely.
well always.
No,
I've
no.
seen some models, some organizations that are doing it exceptionally well. So there is hope, right? And I think that if we band together and really put our heads together and use all the specialists within our interdisciplinary teams that we have access to, boy, are we powerful. So, and actually, we would love to hear from the listeners today. So if you have an impactful story, we would love for you to make a comment on the thread for today's podcast. So share your stories, because if we can unite and share these positive momentums or positive interventions or resources or anything that we can share as a community, really helps us all learn and grow and better serve our patients. So, Chris, this has been a really fantastic discussion. I really want to thank you so much for being a guest today. And to the patients, if you're a patient, you're listening to us, we're here with you. We want to see positive outcomes for you just as much as anyone else. And just know that you do have a team that's behind you. So, all right, Chris, thank you so much again. And within that is a wrap. So as always, I'm your host, Derek, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.